line is muted. Could you please unmute?
Kevin?
Yes.
Hello?
I believe she's transferred us through now.
Okay.
Thank you, everyone, for joining today's Friday Focus program. The title of this session is Joint Venturing, Providers and Payers Pursue Accountable Care. Before I turn it over to our presenters, I'd like to briefly offer a few housekeeping items for your assistance. If you have any questions for our presenters, we encourage you to please post your questions throughout the program by utilizing the live meeting forum. If time doesn't allow for us to address your questions, we'll follow up with you directly after the program. For audio assistance during the program, please press *0. The materials for today's program are available on the live meeting site. Please utilize the icon at the top right of the page, 3 pieces of paper. You can upload from that location. This program will last approximately 1 hour and is being recorded. For those folks interested in COE credit today, we will apply for 1 COE credit after the program. You will need to be uploaded both into the live meeting forum and also via phone in order for you to receive COE credit. And please make sure that both your first and last name and email are noted in that registration process. And now I would like to turn it over to our presenter, Mark Waxman and Kevin Fitzgerald of Foley and Lardner. Mark, please proceed.
Yep, thank you very much. Welcome everybody to our program. Today we're going to be talking about what happens if you decide not to go the ACO route, what the market is telling us is going on. We're going to talk about different opportunities to share risk with managed care payers, either by contracting, and Kevin's going to talk a little bit about some potential opportunities for those of you that have captives. We're also going to talk about some of the challenges presented by the MLR medical loss ratio rule that PPACA adopted as part of that legislation. And let's start just by way of background. I'm a partner in the Boston office of Foley and Lardner. I've been practicing health law for quite a while, and Kevin is a specialist in insurance and has been looking into issues related to insurance, captives, and regulatory issues in that space, and he'll talk a little bit more about himself and his thoughts when I turn it over to Kevin. And now, the reason we came to this program was, as I'm sure many of you did, we looked at the hundreds of pages of proposed regulations related to ACOs and some of the other challenges and said, the problems with the Medicare Shared Savings Program ACO is there are just too many issues. It's too complex. Even now with the pioneer ACOs that are out there, they are uncertain. It still takes an ACO-wide system. You already really should have had experience in coordinating care across your system to do that, and it's not clear where you end up. And, of course, you've got the August application date imminently staring you in the face. There's been a lot of discussion. The ACO returns are too speculative in nature. They require a lot of investment to create that entire structure. Government estimates are one thing, AHA estimates are another, but a pretty wide range of numbers in terms of capital, and then, of course, there's a pretty wide range of human investment. There's the antitrust hurdle that the proposed regs put out there about the potential of having to go through the FTC, DOJ kind of process in order to get a ticket to move forward with your ACO. That creates an additional hurdle beyond just structuring the arrangement. And the issues about collaboration and integration may not be materially decreased. While there's proposed waivers of certain elements of START, the anti-kickback statute, and the CMPs, they may not solve a whole series of underlying risks. And, of course, we still have state issues to deal with about corporate practice, fee splitting, and referral fees. So as we watch the ACO effort go forward, it may or may not happen, but in the meantime, of course, the world itself moves forward. And so we have Congress doing whatever it was that it did, which will have an environmental effect, of course. The available dollars look like they're going down, even with new members coming into the system with insurance in 2014, if the Supreme Court allows it. The capital demand has not abated. There are a lot of other pressures obviously out there beyond the federal government through rate controls with respect to premium increases, either through the federal eye or state enforcement and rate controls at that level. Kevin will talk about the medical loss ratio regulation. And then you have a challenge that, look, if there's no top-line revenue increases through premium, then what does that mean in terms of what's available downstream? And it's easy to see that there is obviously a squeeze going on. So the question comes up, are plans and providers aligned on the issues of how do we go about sharing the dollars that are available, or will sort of ongoing arm's length negotiation continue where everyone is, at least we're all in the same leaky boat together, but let's talk about what techniques we can use to maybe make sure the boat at least sails instead of sinking everybody, and that's what we're going to talk about a little bit today. I think we know what we want. We want systems that promote quality, and you'll see I have payment there because at the end of the day, the payment hydraulics will tell us what kind of system we're ultimately going to have. Quality through clinical integration is a goal. Systems that promote cost accountability through cost control and a fair allocation of the dollars that are paid to those who deliver the service. And we want systems that promote improvement in quality that we can translate to outcomes better than we have now, and of course improvements that are sustained. And all of that has to be done within an existing series of legal constraints. We can't go out and fix prices or really a lot of pressure on overly exerting real market power. Plans at the listening session expressed their ongoing concern with respect to the market power of some systems. The Mass Attorney General looked at pricing and concluded that prices in our state were related to market power in a significant way, so there are issues there one needs to pay attention to. Every day we read about issues with respect to the anti-kickback statute, the START rule, the CMPs, and increasingly some issues with respect to corporate practice are becoming a problem in a number of states, California, Texas being two. So what is it that people are looking at given that complexity? Well, the first thing you start to ask is there a plan-level provider ownership trend starting? Are we starting to see plans acquiring providers in a way that becomes a shift in the market? There have been some 3 high-profile acquisitions lately. WellPoint's acquisition of the CareMore Health Group, which was both Medicare Advantage plans and clinics. The Humana purchase of Concentra. We're talking about a whole series of urgent care centers, which were sort of alternatives to ER services to help drive down costs with capital to be invested in expansion, and the Highmark purchase of the West Penn Allegheny system, which was designed to, I assume, at one level solve some litigation issues, but also to solve what was reported by Highmark to be an effort to attack a market power problem that UPMC had. And so the idea there was to realign the market, Highmark putting in or assuring a significant amount of capital into the system. And so one of the issues is, to what extent will there be an attempt to address the risks and attack costs by the plans now moving more into the provider space? And of course, the goal that everyone talks about in terms of integration is the Kaiser model, that where you really have the insurer, the plan, the hospitals all within, you might say, an overall umbrella held out as one type of integration that people generally perceive, I think, as successful. So one question is, are we going to see a plan-level effort into the provider space? A different model, again, into the provider space that are being thought of are these joint ventures with providers. One that attracted a certain amount of attention was the UNC Blue Cross Blue Shield of North Carolina announcement. which talked about, a collaborative effort to actually build a primary care facility together, to focus care exclusively around that facility on Blue Cross members, where you would attempt to have the practice elements run by the providers, the claims and data elements run by the plan, in a joint venture structure where there was an opportunity for mutual benefit by creating an infrastructure together that would leave the plan doing what it does, claims, data, utilization, those kinds of back office, the providers doing what they do, which is the clinical side, but collectively operating it through a joint venture vehicle to create this sort of win-win structure. And a similar approach, announced with respect to the Horizon Blue Cross Blue Shield in New Jersey with AtlantiCare, again, creating a joint venture model, 50-50 governance, putting together a mission statement that, has all the right goals in it, and can we actually joint venture ways to create better systems for a lot of back office type services, claims, medical management, provider-based administrative services, membership, and the like. In some sense, it reminds us of the MSO models that were around for large physician and PHO type issues, only having the plans joint venture those types of things with the providers. So this is a possibility. When you think about how that works, I pulled out an old 1997 article I had in an HFMA magazine that looked at, how do we evaluate these? And that, those who've been in healthcare a while, so, we're seeing a lot of things come around again, and to some extent again. I thought this presented a good discussion about how to evaluate these types of ventures. You look at, if we're going to joint venture with a plan, then we look at market penetration to see, is there an opportunity for a collaborative product? What will the potential competitive response be? If we're a plan and we joint venture with a single provider for a particular product, what will the competitive response be from other plans? Conversely, if we're a significant provider and we form an exclusive or close to exclusive alignment with one of the plans, how will that affect our relationship with other plans in the market? Market demand. Will a new plan or a new combined product actually find a market? What's the reputation going to be? Will we have, if you look at price, quality, and service, as we compete with other offerings in the market, will we be able to offer the same network access at the same price and the same perceptive quality that's in the market? So this is, how we would evaluate this. Will we have the marketing infrastructure for this joint venture plan and the commitment of that infrastructure to be successful? What's our organizational identity going to be? One of the issues that comes up is, are we going to be perceived as a captive of the provider? Are we going to be perceived as a captive of the plan? And how will the market look at that? At the same time, the issue will have to be addressed. If we're going to make money, are we going to make money in the entity as a whole, or are we going to attempt to make money on the provider side or the plan side? Those are not all the same. We saw issues in this realm come up when we looked before at provider-sponsored plans. Query will ask, are those coming back? But that's another way to joint venture these. What are the financial resources and access to capital that's going to be required for a new product that's a joint venture type of product? We should have the managed care expertise, either from borrowing it, renting it, or using it on the plan side, even if the provider doesn't have it. We should have that expertise in terms of running the system. We should have risk contracting experience, and we should hopefully gain IT infrastructure that maybe together we can develop around a particular product to reduce administrative costs, enhance quality, and develop some market share. As I mentioned before, one of the things that comes up is the converse is, are the providers going to get into provider-sponsored plans more? They were around. Some of them are still around, but will there be a rebirth of provider-sponsored plans or limited provider-sponsored plans, such as the limited Knox-Keene plans in California, which themselves can be joint ventured with plans. And the issues there will be the same as indicated in the 1997 article. Here's the roadmap and the issues that we need to talk about, as we look at these types of ventures. If we're not going to be joint venturing, then we're going to go back to different kinds of contracts. Some of it may be surrogates for joint ventures. Some of it may be simply, how are we going to drive the cost down? And obviously, one way that people are going to try to drive the cost down is simplistically to say, well, let's just pay less. And we'll either do that by tighter case management. We'll look at bundling and editing of bills. And from the plan side, we'll, revisit, how this is handled and how we come up with, are we need to be more focused in this area? Will we have carve-outs where a hospital will have carved out of its contract high-cost drugs, which a plan can perhaps buy cheaper in a different way and then import those into the contract? So, one approach will be let's just pay less. I'm not sure that that's the best alternative. It turns out, I think, not to be so efficient. I'm not sure to what extent, if that's all you're doing, you're incentivizing quality. In our state, there was a lot of discussion about, let's just roll back some of the contracts. And, if we had a 3 or 5 year deal, let's just roll it back and start changing that now. I'll tell you from the provider side, it wasn't all that popular. Does this promote stability if you say we're just going to pay less and that's all you do, and it really doesn't promote care integration? So even if you may save money by paying less on a contracting approach, a one-shot contract probably doesn't accomplish all of the goals that we'd like to see in a high-performing system. I guess the good thing about it is if all we're talking about are discounts, as a way of saving money, we're probably going to be legally protected. We know that there are safe harbors, and let's just focus on the anti-kickback statute, because it really isn't going to be a start problem if you're at the plan level. And there's going to be some discounts that apply to price reductions. And, there are discounts and price reductions, and I'll just kind of go through these as sort of more food for thought. But as you look at, there's a safe harbor when you get into discounts. There are some bells and whistles around it. There are certain things that it has to be. We're not talking about, cash payments. We're not talking about swapping arrangements. I'll discount over here if I still get your Medicare business. In that regard, you might look at Advisory Opinion 1111, which was issued this week, a couple days ago, with respect to issues that come up if it looks like you're swapping, one payer but not the feds. On the Fed side, you look at the way you're going to handle routine waivers or reductions in coinsurance of deductibles. If those become your discounts, you need to be careful. Or if you're discounting services through a PSA, I think you need to be careful there. The rules extend out to, certain applications with respect to who's the buyer and who's the seller, and in general, you'll need to pay attention to the same goods and services purchased within a single fiscal year, claimed within that year or within the next year, and certain reporting rules. I guess the good thing is if you look at the reg, there's no particular limit there about the scope or duration of a discount arrangement or how it may vary with the volume, or even having a quality orientation that says if we provide certain quality, then there'll be a certain discount or penalty type of thing. You look at that, a discount you don't get. And the rule is pretty wide open. Similarly, there's a rule with respect to price reductions to eligible managed care organizations. Again, some of this is fairly technical, but again, there is an application there if you're talking about price reductions to HMOs, competitive medical plans, depending on their status. There's a pretty clear safe harbor that one could attempt to fit into that says let's push forward with respect to these, and you'll look at how these can work, and you fit into them, and you can feel pretty good about what you're doing. Generally, similar to other issues, exceptions in the anti-kickback rule and START, you want agreements in writing at least a year focused on what you're doing within the agreement. You're not going to be swapping, and you're not going to be shifting the burden between programs. And the good news is, as you get into these, it's not just the first tier, it's the first tier and the downstream contractors as well, that with some limitations, you'll be able to fit into these safe harbors for managed care arrangements that are fairly broad in terms of the umbrella that they will cover. A nice thing is if you go beyond the simple price reductions and really get into risk-sharing arrangements like these, capitation percentage of premium or bonus pools with significant incentive P4P payment arrangements, or even the bundles with multiple providers with global rates. As you think about this, you think Prometheus, if you want to look at some of how these work, or the Integrated Healthcare Association, bundled episode payments and gain sharing demonstrations, you'll see that among the things that these kinds of things can do is mitigate the antitrust risk as well. Because if you are engaged in sharing those substantial financial risk in these ways, you're going to get single entity treatment, or treatment that will give you rule of reason treatment as opposed to per se price fixing. And again, I think you will find a relatively hospitable environment as you move through the process and look at not just, of course, the kickback and the Stark issues, but also the antitrust issues as well. There's also, as many of you probably know, when you get into the antitrust side, you can also look to clinical integration as an approach. I think perhaps tougher, because you're not going to find clinical integration listed as an exception for the Stark and the kickback safe harbors. You won't see something that says, and if you clinically integrate. I think then you'll have to be looking at other exceptions in terms of establishing personal services arrangements and fair market value arrangements, and not rely on clinical integration. But if you go that route, you look at clinical integration as an alternative to direct economic integration through substantial financial risk. Clinical integration, not so easy. I think there's been a lot of discussion about it. I think there's been a fair amount of push from the Federation of American Hospitals, the AHA, and others to have the feds loosen up around it. But in general, you'll see here that, here's what it takes: real interdependence, specialist and primary care participation, meaningful information exchange, use of that information, high level of investment, both from the economics and the time, standards, benchmarks that people, in particular the physicians, agree to comply with, and if you don't, there has to be enforcement. So it's a fairly aggressive undertaking. I think it has worked in some situations. I think in other situations, the question is, like the ACO, if you go through it, is there really a there that this is a product that the consuming public, in particular the payers, want to buy? If you do get into substantial financial risk sharing, though, again, there is a safe harbor to look through that will address first-tier relationships between the plans and the providers, and again, the downstream relationships as well, because it's going to say, the rule says remuneration does not include payment between, in essence, the managed care organization and the providers, and then downstream into the providers, if you're bearing substantial financial risk. Looking at capitation, percentage of premium, DRG-based payments, bonus and withhold programs, where you at least have target amounts with respect to the withholds, the bonuses, and so forth, 20% as the target payment on the non-institutional, 10% on the institutional side as thresholds to fall into the safe harbors. So again, if you really are talking about sharing systems with substantial financial risk on the table, then we're going to be able to look to the safe harbors, which once you get into them, again, cast a fairly broad net in terms of allowable conduct. I've been talking about the Stark side of it, the kickback side. Once you shift to the Stark side of the plate, again, the exceptions here, again, are fairly broad in terms of the opportunities they present when you're dealing either with managed care And you'll see you're talking about services to enrollees of HMOs, CMPs, some other managed care organizations. And for those who are pursuing demonstration projects on prepaid basis, this is going to fit into a nice safe harbor on the Stark side. For those who are involved, particularly in the Medicare Advantage world, where you're talking about physician incentive plans between physicians and entities or downstream contractors, where you're talking about withholds, capitation, bonuses, or otherwise, there again is a fairly broad safe harbor if you're bearing substantial financial risk. Again, not a free ride. I mean, you actually have to do that, but where you're really talking about a physician incentive plan that meets those physician incentive plan rules. Risk-sharing arrangements, you'll see there's another stark exception for those that fall into looking at withholds, bonuses, risk pools, and other risk-sharing arrangements. Again, but you can't, of course, violate the anti-kickback statute, which again makes this all, if that's what you're doing, fairly flexible, provided, in general, if you're going to be involved with the physician incentive plan rules, which apply to the MA plans, you're going to have to meet those rules, which have a series of basic requirements. We're going to look to, you're not going to affect cutting off poor Mr. Waxman when he attempts to get his care by incentivizing the Fitzgerald plan. Just don't see that guy. You're not going to be able to do that. You're going to have substantial financial risk protection in the form of stop-loss protection as defined in the reg, particularly if you're in excess of the risk thresholds of 25% of the potential payments. There's rules around panel size one needs to look into, but again, this does create a framework for looking at how you go about presenting application of these safe harbors that will get you out of the risk of anti-kickback and the Stark rules. So you look fairly carefully at those. And then, of course, even if those don't work, you'll go back and make sure that you don't ignore any of the existing exceptions around employment, personal service arrangements, the opportunity to use co-management arrangements. Let's revisit the indirect compensation exception to see if the way we're setting up our opportunities to engage in risk sharing can take advantage of the indirect compensation arrangement exception as well. So as we get into the managed care world and the actual sharing of risk and collaborative behavior between significant physician groups, for example, and plans, it turns out there may well be some real opportunity in the safe harbor world to both comply with some of the antitrust requirements for substantial financial risk and at the same time fall into the safe harbors under the anti-kickback statute and the Stark rules as you structure these kind of arrangements. So where does it leave you? You can think about taking insurance risk if you want to move sort of into that realm, looking at acquisition by a plan, joint venturing with a plan. As a provider, you could go back and look at creating your own plan. Kevin will talk about whether your captive has some opportunity. Or you're going to look at taking contracting risk through contracting, with a real move into risk-based contracts, taking advantage of the Stark exceptions, the anti-kickback exceptions, and I should have put, also making sure you don't run afoul of the CMPs, which far less likely, at the same time qualifying for rule of reason treatment under the antitrust laws. Kind of a mouthful in a half hour, but really designed to get you thinking about pushing forward in what the opportunities are as opposed to perhaps the headaches once you take advantage of some of these managed care exceptions. Now let me turn it over to Kevin, who's going to talk about what some of the bells and whistles and guardrails may be around the medical loss ratio impacts that you may not have thought of. Kevin?
Thanks, Mark. First, just a little bit of background about myself. As Mark mentioned, I'm a partner at Foley and Lardner in the insurance group. The vast majority of my time is involved in corporate and regulatory work for insurance companies. I also spend a significant amount of time with larger organizations that are establishing captive insurance companies, and that'll be one of the two themes that I'll be covering. First, I'm going to try to provide some thoughts and insights on the medical loss ratio requirements and how these requirements can and probably will impact various sharing arrangements that Mark has just been discussing, as well as the captive structure that I'll be talking about in a minute. Real basically, the medical loss ratio is a requirement to the federal law where health plans or insurance companies providing health insurance need to spend, either 80 or 85% of every premium dollar on medical expenses or quality investment measures. And so the formula for it's a fairly simple formula. You have your claims plus your quality improvement measures, and you divide, what you spend on those two items by your premiums, net of any taxes and fees. And what this really means is, for large groups, you have to spend 85 cents of every dollar, and for small groups and individuals, the insurance company needs to spend 80 cents of every dollar collected. And that obviously is going to put some significant pressure because then within that 20 or even sometimes 15% margin, the insurance company obviously needs to cover its overhead, pay for brokerage commissions, although that's a slightly an open issue because there's some push to have the broker's commissions pulled out of the premium number, out of the denominator, if you will, and then have their corporate profit all within that fairly narrow margin. Also important, I think, is the fact that based on some national studies, a significant number of the current health insurers in the market, we're not meeting these minimum medical loss ratio requirements, meaning that they are, currently, in fact, collecting too much premium or spending too little on care. But again, it's what you give in one place, you have to take back in another. Also important for some of the slides later on, medical loss ratios are calculated first by state, so by geographic region. So every health plan will have a different MLR in each state that it does business in. It's also calculated by each health insurance market. So they do an MLR calculation for large group, they do a MLR calculation for small group, and they do an MLR calculation for individuals. There are also special rules for multi-state groups. Those get cited to the state where the contract is located, and then there are special rules for individuals buying insurance through associations and for small employers buying health insurance through MIWAs. But again, we don't need to get into those details today. So, we've been discussing about, payor risk-sharing arrangements and how could the, MLR impact these provider-payor relationships. First of all, if you get some of the benefits that, that Mark's indicated, better quality of care, fewer and lower claim costs, that can be beneficial to, the industry as a whole, and there's a number of advantages. But ultimately, that directly will lower the medical loss ratios for the health insurers, which, again, as based on a previous slide, could result in a requirement that the insurance company rebate any excess premium back to the policyholders. So, that is an issue, a bit of a tension, if you will. The goal of reducing costs will necessarily drive lower premium charges for both current years and future years. As I mentioned, a substantial number of health insurers are not currently meeting or were not meeting at the time the law was passed, the MLR requirements. And again, to the extent that there's reduced costs in the healthcare delivery system, that's actually driving them farther away from meeting the MLR requirements rather than getting them closer to it. And so that could be, somewhat problematic, if you will. And one of the advantages we'll be talking about under the captive programs and the joint venturing programs generally, a large health insurer joint venturing with a large healthcare provider could provide a benefit of an increased, premium growth for the insurer. They get a larger block of policyholders if they're able to successfully partner or joint venture with a healthcare provider. But obviously, again, the requirement under the MLR rules to rebate premium for a successful joint venture could in fact negate the benefit of some of that premium growth. Now, the good news is, and these rules are obviously brand new, and there's still lots of debate about them, and I suspect there will be substantial interpretive guidance. But the question really flows down to, what can be included and what cannot be included in the numerator. What's going to drive the loss ratio up to that minimum 80 or 85%? Again, I think the denominator is not particularly relevant for this call. It's premium less taxes and fees, and brokerage commissions may be in or out, but ultimately that number is going to be relatively static. So really the question becomes, what can go into the numerator? And the answer, is really that, there's a number of things that can go into the numerator. Obviously, capitation payments can go in, as well as incentive and bonus payments made to providers. Now, what's important here is that these are not considered, particularly focusing on the incentive and bonus payments made to providers. These are not considered quality improvement expenses. They are, in fact, considered to be incurred claims. Some of the examples include things where, there's a medical incentive pool where the insurer either, shares some savings or makes incentive payments to the provider. These are legitimate expenses that can be added to the numerator. And so, those are very helpful factors because it would preserve the ability to do some of the arrangements, the contractual arrangements in particular, that Mark was discussing in the first half of this presentation. Now, what can't be included, obviously, is what is more generically considered, administrative services. And this will get particularly complicated, I suspect. We'll go to the next slide. When we talk about some of the capitation models. So, again, as we said, the incentive and bonus payments can be counted in the numerator of the MLR. Therefore, there's a logical support for those types of structures for insurance companies over some of the other types of structures. Capitation models are also favorable because, again, the capitation payment can be included in the numerator for purposes of the medical loss ratio calculation, with a caveat. The portion of the capitation payment that's associated with administrative costs as opposed to the provision of medical care likely cannot be included in the numerator. And again, this is one of those areas where there's likely to be a substantial amount of, additional guidance. So we could go through some examples. If you have a capitation arrangement where the health plan is paying the provider, fill in the blank, $100 per member per month for the provision of medical care, that $100 would go into the numerator and would be deemed a claims expense. But if that capitation arrangement said that, the healthcare provider would also provide other types of services that are not considered to be medical expense and not considered to be quality improvement expenses, then the likelihood is that a portion of the capitation payment associated with those services could not be included in the numerator and would have to be, in effect, removed from the calculation. So if utilization management is something that the provider is going to do as a service under the capitation arrangement, and if the insurance company or ultimately the federal government concluded that, $10 of that $100 capitation payment was really for then that's going to come out of the numerator, thus driving down the medical loss ratio and perhaps requiring the insurance company to return fees, to return premium. And again, there's examples of administrative things, medical record copying costs, janitors, I'm not quite sure why they were singled out among all of the employees of a healthcare system, quality assurance analysts, secretaries to medical personnel. So, in one sense, if you say we're paying $100 per member per month to provide health care, and you're silent on, and we don't care how you pay your staff and your secretaries, one could again argue that $100 ought to be, covered as a medical expense and therefore in the numerator. But to the extent you're adding specific services, or to the extent that that capitation payment was somehow fairly clearly supporting, administrative tasks at the healthcare system, I think you could run into situations where, again, someone was going to require that those numbers be removed from the numerator. The Medicare Advantage plans, Mark touched on those briefly. They're going to be subject to an 85% MLR requirement, the good news is that those rules don't come into apply until 2014, and in fact, the regulations that have been written for the commercial business are not likely to be, verbatim adopt for Medicare Advantage plans, although certainly they're likely to be somewhat precedential. There have been some surveys, and actually on the Medicare Advantage plans, most of the industry was in the 84.5% to kind of 86% range. So this might not be a significant, target for these plans to meet. So in any event, one of the issues is going to be, you got a couple of years to do what you want to do or can do under a variety of contracting and compensation arrangements. But at some point in 2014, the medical loss ratio is going to apply to these types of plans as well. Okay, now I'm going to talk about captive reinsurance arrangements for a moment as just an alternative to the several different structures that Mark spoke about during the first half of this presentation. Basically, a captive, for those of you not familiar with it, is simply an insurance company that, in our example here, will be owned either by a healthcare system, a provider group, some organization on the provider side. Many large healthcare systems and even large physician groups already own or have access to captive insurance companies. They're fairly common in the medical malpractice arena. So those types of again, large systems typically use their captive insurance company to provide med mal cover. They may also use it to provide workers' comp or general liability or other types of exposures as well. And so the idea that we've been kind of discussing in-house here at Foley is the idea of utilizing, having the providers, utilize their existing captive insurance company to take on some of the insurance risk of the underlying health insurance policy by entering into reinsurance agreements with the health plan or the health insurer that is providing the insurance policies, to the public. And so the structure would look something like this. And again, there's as many structures as there are people in the room. But let's say, ABC Insurance Company is a health plan in a particular state. They've got a number of products on the market, and they want to do a joint venture arrangement with the largest healthcare system in that region. So they go out and develop a new insurance product with a narrow network, a defined network, where the benefits are most advantageous for the policyholders, for the customers, if they go to the healthcare system that the insurance company is joint venturing with. And then, the providers would obviously consult with the insurance company on the development of the product, what's covered, and those sorts of things. But then they would have their captive insurance company enter into a reinsurance agreement and take a percentage of the risk on each health insurance policy issued in exchange for taking a percentage of the premium. And so the example here is simple, what we call quota share reinsurance, where 50%, and again, you could change it 70-30 or 60-40 or even 90-10, but for simplicity, we would say 50% of the risk that the insurance company has on its books when it writes the policy will be transferred to the captive in exchange for transferring 50% of the premium, 50% of the premium as well. Some of the benefits for the providers, obviously, this is kind of a, I think Mark used the word, having the providers having their own health plan. This is a way for you to have access to having your own health plan without having to build a full health plan from the ground up. You don't have to get a fully licensed insurance company up and running and capitalized and deal with the regulation associated with that. You won't have to develop the product and do the actuarial work, on your own, if you will. But by using the reinsurance structure where your captive takes, 50% of the risk and 50% of the premium, you're effectively in the economic position of owning half of the insurance company, at least with respect to that discrete book of business. And so, that gets you in the business. And obviously, if you can, reduce costs through good healthcare services, more efficient healthcare services, better care coordination, that lower loss experience will inure to the benefit of the captive, which the provider, is the owner of. So the ideal would be that this, financial benefit will incentivize the type of better care that we've been talking about. There'd also be an ancillary benefit from a tax standpoint, and I'll try to, drill down 20 years of tax law into about a minute. For a captive insurance company to be treated as an insurance company for tax purposes, it needs to meet certain tax rules, if you will. And this is important for many captive owners because if the captive does not meet the IRS test, then the premium that the provider is paying to the captive will not be tax deductible. A significant tax benefit can be lost. So, for example, if you have a single hospital owns 100% of a captive insurance company, and they use that captive insurance company to provide medical malpractice insurance to the hospital system, that likely will fail the test that the IRS has set out because it fails to meet the risk transfer and risk distribution rules. It's basically the hospital is just dumping its liability into a wholly owned subsidiary, which it owns. And so in that example, the captive would not be treated as an insurance company, and the premiums paid by the hospital to its subsidiary would not be tax deductible. In order to pass the IRS test, you need to have a number of parties paying premium into the captive, and ideally you would have some unaffiliated third-party risk. So if a hospital system owns 15 hospitals, and those 15 hospitals are all paying premium to a sister corporation for the provision of medical malpractice insurance, that type of structure is likely to satisfy the IRS requirements. By adding third-party risks, namely the health insurance risk of citizens in the community, you just strengthen the position that the captive has from a tax standpoint because the captive begins to look like a real insurance company because it has the third-party risk as well as the risks of a number of affiliated companies. Now, having said that, if your healthcare system is a nonprofit and the deductibility of the premium isn't a significant issue, there can actually be advantages to the group by purposely failing the IRS test on whether something is an insurance company. In any event, that was about 20 years of tax law in just a couple minutes. Benefits for the insurer, I think I touched on these a little bit at the front end. It can create a new premium stream. They've got a narrow network product with a large provider in the area that can give them, a very some premium growth in a market that could otherwise be flat. Obviously, to the extent they can generate better loss experience through the provider joint venturing arrangement with the captive involved, obviously that provides some greater profit for the insurance company. And there's also the possibility of transferring a portion of the administrative costs to the captive, which can be beneficial to the insurance company overall. Now, of course, those last two bullet points again, remain subject to the MLR rules. So transferring overhead to the captive and reducing costs, may not ultimately be too beneficial for the insurance company, since it still needs to meet, the federal requirement for the medical loss ratio. But here's there's a fairly complicated possible, methodology with respect to how a health plan and a captive that's owned by providers might calculate medical loss ratio. As I said on the first slide, the insurance company, the health plan on the front end, has to calculate it by state and by, group size, large group, small group, or individual. Logically, the insurance company and the captive would use those same formulas, if you will, to say that if the insurance business between the health insurer and the captive has a large group component, a small group component, and an individual component, they can calculate medical loss ratios on each of those three discrete books of business. And if the medical loss ratio is below the federal mandate, then likely the reinsurance agreement would say that the captive must return premium to the health insurer, because the health insurer is going to be required to return the premium to the policyholder. And since the captive is sharing, all of the risks of the health insurer or the health plan, one of those risks is the obligation to return premium in the event medical loss ratios fail to meet the minimum. Now, where it gets a little more complicated is, what if the business that the health insurer writes outside of the captive has a 90% loss ratio, but the health insurance business that goes into the captive, because of the joint venturing relationship issue, and quality of care and coordination of care, has a 60% loss ratio. At the front end, the health plan isn't going to be returning any premium to any of the policyholders, because their company-wide business, if you will, exceeds the 80 or 85% medical loss ratio requirement. Under that scenario, if you're the provider and you're negotiating the reinsurance agreement with the captive, you would want to argue, well, we won't, even though our medical loss ratio on this discrete book of business that's subject to the reinsurance is below the 80 or 85%, we won't be obligated to return any premium to the health plan unless and until the health plan is obligated to return premium to policyholders. So in a sense, the captive owned by the provider could, if they properly manage costs in the discrete book of business at issue here, generate a substantially lower loss ratio and therefore more profits for the captive, inuring to the benefit of the provider. Of course, as soon as you come up with that example, you can come up with the exact opposite example, where the health plan has on its kind of statewide business a medical loss ratio of 75%, meaning they're going to be obligated to return premiums to policyholders, while hypothetically the business that's subject to the reinsurance agreement with the captive might be running at a 90%. And so now, again, having just the exact opposite, would the captive have to return premium to the health plan so that the health plan can return it to policyholders, when on its very small book of business it's running at a fairly high loss ratio? That type of issue is certainly going to be one of the most significant issues in the reinsurance agreement between the health plan and the captive. Obviously, it's a business issue. There's no right or wrong way from a legal perspective, but it is something that has to be worked out. The last issue I wanted to touch on, and then we've saved a few minutes for questions, is how do you get out of the program? I think in Mark's many examples, some of them are contractual and you can exit them by terminating the contract. Some of them are more, substantive, forming your own health plan as a provider. A little bit harder to exit that business line because it's more difficult to exit from being a full health insurer. The captive reinsurance structure really is more on the contractual side than the forming a full health plan side. Namely, it is a contract. That contract can be terminated or non-renewed based on, again, whatever the terms are that are negotiated between the health plan and the captive. And so the exit strategy, if you will, for the provider who may in 2 or 3 or 5 years decide that they don't want to be a risk-sharing partner on the health insurance risk, they can exit it. Now, one of the things when they exit is going to be whether or not, who keeps the underlying business that's been in place for those 3 to 5 years. Under the contract, under the insurance contract and the law kind of right out of the box, the health plan still has those relationships with the policyholders and could do with those clients, customers, if you will, pretty much however they want, even though they have for years been, patients of the healthcare system. And so there may be some desire by the provider that owns the captive to somehow limit the ability of the health plan to take that business and go somewhere else. So, for example, let's say there's 2 large competing healthcare providers in a particular market, and the largest health plan develops with provider A this joint venture arrangement, this narrow network product, this captive reinsurance structure. It works for 5 years. The provider says, I don't particularly like it. I'd like to exit this program. And then, in worst case scenario, that for the provider, that the health plan says, well, okay, I've got a narrow network product that's designed. I'm just going to change the name of the network and move the entire block of business over to the other healthcare system. So, again, those types of issues can be dealt with in the contracts. You can put in, some kind of non-competes and other types of provisions. But ultimately, it is something that would need to be negotiated on the front end, as is true of almost any contractual arrangement. Okay, we kept it to 58.5 minutes. We have a couple of minutes for questions, and as was announced at the beginning, any questions we're not able to answer, we can respond to later.
Kevin, let me ask you this question. Let me just start. The question is, if you're in a situation where the medical loss ratio rules apply and you have a contract between a health plan and a provider that shares a savings in the medical loss ratio that takes you, let's suppose the medical loss ratio is now 90 and you agree to share 50-50 savings in the medical loss ratio down to 70. If the medical loss ratio is applicable, does it do you any good to go below the floor?
From the insurance company's side, absolutely not. From the provider's side, sure, if they can get that kind of contract. Because if, to the extent the medical loss ratio falls below the floor, the health plan, the insurance company is going to have to return that premium to the policyholder. If they are also making payments to the provider network based on those same savings, they'll be paying twice, or in your example, since it's a 50-50 sharing, they'd be paying, 1.5 times. 100% of it would go back to the policyholder and 50% of it would go to the provider. Now, if it was properly structured, kind of back to my first couple of slides on the medical loss ratio and what's included, if the compensation payments to the provider can be characterized as some form of, incentive and bonus payment that under the rules would increase the medical loss ratio, then that would at least eliminate the double payment by the insurance company. So in that situation, you can, the provider can win without the insurance company having to lose. So again, properly structured, it could work.
And I think it suggests that we're going to have to pay very close attention to the contracts between plans and providers engaged in risk sharing in terms of classification of expenses, but also what happens in the event that there is going to be a potential, I'll say, rebate as a result of the MLR bite. I think as we get closer to 2014, in particular with the MA plans, we're going to look at some creative drafting to try to ensure that the parties' expectations are met.
Well, and the captive structure, for example, isn't really mutually exclusive to any of the structures that you described. There might be some redundancy in having both types of profit and loss sharing arrangements in place, but you could certainly have a captive reinsurance structure for 50% of the premium and 50% of the losses and still have some type of capitation arrangement on the pure provider side. So you can, blend both types of joint venture arrangements, although at some point it might become a bit redundant.
Yeah, I think you have a question about case management, disease management. Where does that fit in the MLR calculation?
Most of those types, certainly the utilization management is not in the numerator. Case management is probably not. Again, the rules have just, are relatively new yet, and some of these details are still being worked out. We could certainly, provide a little more clarity in a subsequent write-up.
I think we have a question about, how if you got into a health plan kind of captive arrangement, how would the claims be paid for covered services? My sense is there would be no particular reason to change the existing claims payment methodology unless there was really an administrative reason to do so.
That's right. In a traditional captive reinsurance structure, whether it's for MedNow or for the health insurances we've described it, the insurance company generally does all or most of the administrative services that they've always done: premium collection, claims administration, those types of services. And the captive is simply viewed as a bank account, really, a very passive party from an operational standpoint. Now, we had talked about the ability to use a captive to transfer some of the administrative expenses to the captive away from the insurance company. So you could certainly have the captive insurance company providing some of the whether it's back office or other administrative functions. But generally, that's not likely to be real efficient. I mean, the health plan is in that business, day in and day out. That is its business. It's likely going to be more efficient for the health plan to continue to handle everything in the ordinary course. In effect, the people on the ground at the health insurer aren't going to know when they pay a claim that this claim is subject to a 50% quota share reinsurance agreement and this one next door to them isn't. That's going to be done, again, in a back office on the accounting side.
So I think we've gone a little over our time. If folks have other questions, just send them in, and Kevin or I will be more than happy to answer them offline or call you directly. So we thank you very much for joining us today.
Case management.
Ladies and gentlemen, that does conclude your conference. You may all disconnect and have a